Good evening, everyone. Welcome to APOS Oculoplasty webinar series 8. Today's topic is decision making and surgical principles in proptosis. Now, I welcome Dr. Subramaniam sir to deliver his talk.
Thank you, Sudhakar.
Welcome to APOS Oculoplasty webinar series 8.
Very good evening to everyone. So I'll be reading today about the decision making in proptosis and then management of it. Okay. So for those who might not have attended the last few classes, I would like to take a few minutes about the diagnosis and important aspects of CT, which both are very, very essential to come at a diagnosis. Then we will go into the decision making in each and every case. What are the different management strategies that are available in the management of proptosis and the
So make it slideshow mode, sir. Done.
Okay. Right. So, what are the various management strategies that are available? It could be observation and reassurance alone, or a medical management, surgical management, which could be a purely orbital surgery, or a multi-specialty approach, radiotherapy, and chemotherapy. As you are aware, orbit comprises of so many different types of structures like blood vessels, muscles, fat, glands, nerves, eyeball, etc., lymphatics and all these things, so that almost all the diseases that can occur in the body can occur in the body. So the pathology is very, very varied, and so is the management strategies. So what are the factors which define our decision? It depends on the nature of the lesion and location of the lesion. If it is whether the lesion is infective, cystic, or whether it is neoplastic. Neoplastic could be benign or malignant. Malignant could be primary, secondary from the surrounding structure, or metastatic from distant organs. And the location of the lesion is very important in making the strategy, especially for surgery. Whether the tumor is intracornal or whether the tumor is in the peripheral surgical space, anterior, superior, inferior, medial, or lateral, or whether it is extending to surrounding structures like paranasal sinuses, intracranial space, etc. Depending on the location, we derive at what procedure we would like to make. So the diagnosis depends on the detailed clinical evaluation and imaging, which could be CT or MRI. For me, my preferred imaging technique is CT, and if necessary, we can go for a FNAC, fine needle aspiration cytology, squash smear, biopsy, and IHC, immunohistochemistry cytology. So immunohistochemistry, which can definitely pinpoint the diagnosis whenever there's a doubt with an picture. A little about the sections, their levels, and other. I'm going to repeat for the sake of those who missed the class last time. The level of the lesion axially is from below upwards. The sections will be taken. So, to know the level of lesion, first look at the medial walls. If they are parallel, the level of the lesion is in the mid-orbit. You will be usually seeing the medial rectus and the lateral rectus muscles also. Behind, you may be seeing a bit of a brain. In front, you will be seeing the nose, which is mildly prominent, not too prominent. In the superior sections, behind you see the crista galli, and in front you see flat, which is the root of the nose. Whereas inferior sections, you will be seeing a very prominent nose in the front, and behind it is oropharynx, which is black, very dark black, and because it contains air in the sinuses. That's oropharynx. So the normal anatomy that you see is in the mid-level, you can see the lens, the vitreous cavity, the medial rectus, optic nerve, the lateral rectus, ethmoid sinus, posterior. This is the sphenoid sinus. This is the optic nerve canal, and this is the superior orbital fissure. This is the anterior glenoid process. This is the optic canal. So in the superior cuts, you will see the reflected tendon of the superior oblique. This is the lacrimal gland. This is the zygoma. This is the sphenoid bone, superior ophthalmic vein, temporalis muscle, and the crista galli. The common mistakes that one, especially residents, make is in the axial sections. Remember that the optic nerve is not straight and it may not come as a single, as you see here. There is a small sinuous course of the optic nerve, in which situation there will be an apparent discontinuity, as you see here. This is normal. Number two, temporal or lateral to the optic nerve, you may be finding a cyst in every case. This is present. This is nothing but the coronal section of the eyeball, and this is the sclera, and this is the vitreous. Remember that optic nerve is not the posterior most part of the globe. The posterior most part is lateral to it. So that this, what you are seeing is section of the eyeball. When you look at this is wide when compared to the left side. Many people used to comment that this is enlarged optic nerve. Optic canal is enlarged, and there's the extension of the mass through the optic canal into the brain. It's wrong. This is a mid-cut, and this is the superior ophthalmic fissure, which is enlarged when compared to here. So, if you are seeing the optic nerve, there must be one more fissure. So, this is the superior ophthalmic fissure, and medial to that is the canal of the optic nerve. So, this you have to remember. Unless you see two apertures, don't comment that it is optic canal. Optic canal, then there are two fissures. The medial one is the optic canal, as you see here. The lateral one is the superior orbital fissure. CT interpretation, how to read. There is a systematic way: anatomical location or level, bony orbit, eyeball, extraocular muscles, optic nerve. In the soft tissue lesions, look at the borders, the consistency, Hounsfield units, and contrast enhancement. So in the bone, when there is a prolonged pressure by a benign tumor, there will be an excavation. The bone yields. There is a concavity will be there. This is called excavation. When there is a malignant lesion or a fungal lesion, the bone gets eroded. This is called erosion. The surface you can see that is irregular, whereas the surface here is very smooth and concave. So this is hyperostosis of the bone with irregularity, and you can see a tumor with an intracorneal component. So intracranial component, orbital component, and a component in the temporal fossa. This is sphenoid meningioma. That's why there will be temporal fullness because of this temporal component. This is a bone with fibrous dysplasia. This is osteoma of the bone where you can see uniformly thick with oscillated appearance in the bone window pictures. In the bone window, if you look at this, here is a fracture of the floor with teardrop sign, and muscle is not incarcerated, whereas here is a big, huge fracture with herniation of the tissues into the sinuses and incarceration of the inferior rectus into the bone. This may not require any surgery, but this definitely requires. Look at the globe and what is happening. When there is a molding like this means that it is a very soft tissue that is there. It usually occurs in lymphomas, renal cystic carcinoma of the lacrimal gland, and occasionally in fungus granules. Or if the tumor is, or if the lesion is, this is the lesion, I'm sorry, this is the lesion. If the lesion is very firm, what it can do, this is a hydatidiasis, it can compress the optical eyeball and make it flat. Look at the change in the contour for this and the presence of normal contour in this case. And if there is severe proptosis, the optic nerve stretches to some extent and then it cannot, then there will be tenting of the optic globe. You look at this posterior pole and the change is the normal posterior pole, the change in the curvature of the posterior pole and the shape of the posterior pole. There could be intraocular tumors in a child with calcification, as you see here, and with orbital extension, as you see here, and with the intracranial extension here in this child. There's typical of retinoblastoma. Whereas a brownish mass with a typical apex uniform in consistency and no calcification is typical of melanoma. Thyroid-related orbitopathy and idiopathic orbital inflammatory syndrome. Thyroid-related orbitopathy, the muscles are enlarged with sparing of the tendon, and more than one muscle is usually involved, and usually both the eyes are involved, even if there is not much of a proptosis in the second eye. Single lateral rectus muscle involvement is not heard of in thyroid eye disease. There is no enhancement of the muscle, fat, lacrimal gland, or optic nerve in thyroid-related orbitopathy. Whereas in idiopathic orbital inflammatory syndrome, which could be unilateral or bilateral, there could be single lateral rectus muscle involvement, as you see in this patient both eyes, with involvement of the tendon. Here the lacrimal glands are also involved and there is contrast enhancement is present. A bit of fat is seen in here. This is enhanced. This is very typical of idiopathic orbital inflammatory syndrome. Enlarged extraocular muscles can be seen in cysticercosis. This is the reflected tendon of the superior oblique, and this is the muscle with cysts involving both the muscle belly and the reflected tendon. Here you can see engorged superior ophthalmic vein with mild engorgement of the extraocular muscles. This is the engorged superior ophthalmic vein when compared with the normal on the opposite side. This is typical of carotid cavernous fistula, probably low flow. This is high flow carotid cavernous fistula, where there is a gross enlargement of the superior ophthalmic vein. This is the normal, and this is the grossly engorged superior ophthalmic vein with the gross engorgement of the inferior rectus and the medial rectus, lateral rectus, and all the muscles. So this is typical of carotid cavernous fistula. Coming to the optic nerve lesions, the two important things are optic nerve glioma and optic nerve sheath meningioma. So these are the axial cuts of optic nerve glioma and meningioma. Glioma is has very clear-cut, smooth surfaces, and it is uniformly hyperdense, right? The edges are very, very clear-cut edges. It's as if an encapsulated tumor. Whereas, in case of meningioma, the surface is irregular, as you can see here. Then it is not uniformly dense. It is hyperdense in certain areas. This is because of calcification. And in between, you can see the hypodense area is the optic nerve. This is called the tram track appearance. And contrast enhancement occurs in optic nerve sheath meningioma, whereas contrast enhancements does not occur in optic nerve glioma. The same optic nerve glioma, nerve sheath meningioma in coronal sections. Again, you can see very clear-cut, smooth borders in the optic nerve glioma with isodense and uniform dense mass. You cannot see the optic nerve separately from it. As you see that this is the optic nerve, you can't see the optic nerve separate from it. This is optic nerve glioma. No contrast enhancement. Whereas you can see that the surface in the nerve sheath meningioma is very irregular, very infiltrating and irregular. And it's not uniformly dense. Certain hyperdense areas, certain hypodense areas, certain normal area. And this hypodense area in the center is the optic nerve. Contrast enhancement occurs. Calcification occurs. That's how it's very easily we can separate optic nerve glioma from optic nerve sheath meningioma. So you have to know whether the features are suggestive of a benign tumor or a malignant tumor. Here you can see that the tumor is very well circumscribed. There is a mild excavation of the bone, very smooth, with liboliths. This is a long-standing tumor, 2 years duration. This is typically a benign cavernous meningioma. Whereas if you see this tumor, there is excavation of the tumor. This is very smooth. So this is the coronal section of the same tumor. But if you look at this, this is the eyeball. Superiorly, you are seeing an area with infiltrating irregular margins that you can see. The margins are not very clear cut. Even it is not uniformly dense, some hyperdense and some hypodense areas. And look at the bone. The bone is eroded. You can see the irregularities. So same case in this. The lateral wall, you can see the margins are a bit irregular. The bone is eroded. Its contrast enhancement is present. This is malignant. So what are the strategies? Observation and counseling and medical management. Nearly 45 to 50% of cases of proptosis are managed conservatively. It's only in about 50% of cases you require to do a big surgery. In nearly half the cases, if you understand the disease properly, you can manage conservatively either by observation or counseling and reassurance. Surgical management, it can start with FNAC, biopsy, excision of the mass if it is a benign one, or if it is a malignant, you may be doing a debulking. So you are doing an orbitotomy or an exenteration, or it could be a multi-specialty approach, and referral to a radiologist or oncologist. Observation and reassurance. So this is a typical case of minimal, what do you see here? Shallowness in the left eye with a minimal ptosis, and the eye is a bit shrunken. And on Valsalva maneuver, what has happened? It has become more proptose, and there is a fullness, and the evert the leak, you can see the vascular mass. This is typical of orbital varix. Orbital varix, we are not doing any surgery, just to reassure the patient that nothing harmful is going to happen, and we can reassure the patient. We don't do anything. Here is a young lady with a thyroid associated orbitopathy with very minimal 1 millimeter liquid retraction. It's there since 1.5 years. So just nothing else need to be done for her. She looks pretty good. At the most, we can give a triamcinolone or Botox injection, but for 1 millimeter bilateral symmetrical, she is quite happy and comfortable with that. So just we'll observe her till the period of 2 years of the disease is over and nothing else need be done. For majority of the cases of thyroid associated orbitopathy, which occur in young individuals, most of them require observation, reassurance, and proper counseling. That's all what is needed. No big surgery is needed in such situations. Coming to the medical management can be in infections, like which could be specific infections like tuberculosis or non-specific infections. Inflammations like idiopathic orbital inflammatory syndrome or non-specific orbital inflammatory syndrome, vaginal granulomatosis, etc. Cysticercosis, and majority of the thyroid associated orbitopathy which have symptoms like inflammatory symptoms are treated with medical management. And even optic nerve compression can be treated with medical management, first with IV pulse steroids. And if the patient responds, surgery need not be done. So, medical management has a very, very important role, especially in DAO, which is the most common cause of both unilateral as well as bilateral proptosis. This is a cysticercosis case that you have seen previously, which has been managed with albendazole at a dose of 15 milligrams per kg body weight per day in 2 divided doses for a period of 4 weeks, along with prednisolone at a dose of 2 milligrams per kg body weight and tapered over 4 weeks' time. Since the inflammation is very severe in this girl, we started prednisolone with 2 milligrams per kg body weight. If the inflammation is mild, we'll start with 1 milligram per kg body weight of prednisolone. Case of orbital cellulitis with motility restriction, you can see severe edema, fullness, pain, tenderness, congestion, motility restriction, the eye is not moving, with IV antibiotics, and later with a bit of small dose of steroids also combined. She has recovered in 2 weeks very well. FNAC. When do you do FNAC? To do FNAC is when you are suspecting especially a metastatic lesion. Then normally we look at a fine needle aspiration cytology. So this young male presented with proptosis of the right eye with motility restriction of very short duration, no other symptom, and the CT scan shows a mass in the superior space with irregular consistency and erosion of the bones, which is suggestive of the metastasis. So we did a FNAC instead of a big surgery and a biopsy. And FNAC was positive. You can see a rosette, tumor cells arranged in like a rosette. So this is from neuroblastoma, medulla. This lady came with proptosis of the right eye with motility restriction and pain of 1 month duration, history of radical mastectomy 2 years back. CT shows enlarged lateral rectus muscle, and you can see erosion of the bone and also the hypertrophy of the bone with the erosion. That means the it is invading the bone. So we did a CT, we did a FNAC. The FNAC showed the cells arranged with nucleus outside towards the cytoplasm, outside the cytoplasm, extracellularly, and this is typical of ductal carcinoma of the breast. Refer to oncologist. As I said in the previous cases, this is the typical pinkish mass that's called the Salmon's patch, which could be coming from the fornix towards the limbus, or which may be starting at the limbus and going towards the border. This is typical of lymphoma. The diagnosis is almost written on that. When once you see this case, then what you do, you take a biopsy, and the histopathology shows lymphoma. This is a typical picture of lymphoma with round cells, hyperchromatic nucleus. So, patient has been referred to a radiation oncologist for further evaluation and radiotherapy. This patient came with severe pain, proptosis, and with a history which said that there is a history of tuberculosis, for which he did not take proper treatment. So he did not take proper treatment. He discontinued after 3 months. There's severe pain, severe proptosis, and the vision is so clear. And the CT scan shows something irregular with a cavity and all that, something around the optic nerve. I thought it may be an abscess, a cold abscess or something like that. So I wanted to drain it. I wanted to see what it is because the diagnosis is not clear. So I did a lateral orbitotomy. You can see that this is the optic nerve. Around the optic nerve, you can see something pinkish marks, which I have biopsied, and on IHC it was found to be a case of lymphoma. This patient has been referred to a radiation oncologist, had a course of radiation, and with that the tumor has totally melted. And this is how the patient was looking, with total complete resolution of proptosis. Cysticercosis, we'll leave it there. Here you can see a patient with proptosis of the right eye, and the right eye is not abducting. That means the lateral rectus is paralyzed. You can see caput medusae, engorged blood vessels, and the CT shows engorged superior ophthalmic vein on that side, with increase in the size of the extraocular muscles. This is typical of carotid cavernous fistula. So our role is up to making the diagnosis, and then we refer the patient to an interventional radiologist who will make the further investigations and probably loses it either with embolization or with. So this is the surgical management if we are thinking of. The bulk is orbitotomies, that's what we do. It could be for a biopsy or excision or debulking. The other surgeries could be orbital decompression in thyroid orbitopathy not responding to medical treatment. Or there could be multi-specialty approaches where it is extending to or coming from neighboring structures like sinuses or brain, and rarely we may need to do exenteration. So there is the common and most commonly used incisions for orbitotomy. This is the subciliary incision of Benedict just below the eyebrow. B is the vertical lid split incision of Byron Smith, which is not a great incision because it leaves a huge vertical scar. Then C is the Lynch incision for the medial peripheral surgical space, and this is D is Gullwing incision for the medial peripheral surgical space. E is subciliary incision in the lower lid for the inferior peripheral surgical space. So F is superior lid crease incision. Superior lid crease incision can be extended as a lateral orbitotomy incision, or if it is a peripheral surgical space in which the tumor is present superiorly, just we can do a superior lid crease incision of Harrison. This is the typical stellar right incision, which then you can have a limbal incision, which I prefer to do under big anterolateral orbitotomies, and then a subcaruncular incision, and this is the we split the lateral canthus and invert the lid and go through the conjunctiva. That is called swinging lower lid incision. This is the transcaruncular incision by Goldberg. Now let's look at the CT scan. The CT scan shows a mass which is purely intracorneal. So the approaches that are available are lateral orbitotomy, anterolateral orbitotomy, and transcoronal approach. What to choose and when to choose. So then first thing when you see a lesion which is in the intracorneal space, first thing you want to know is the optic nerve seen separately from the lesion? As you can see here, the optic nerve is seen separately from the lesion. When the optic nerve is not seen separately from the lesion, it means it is coming from the optic nerve. It could be glioma or a nerve sheath meningioma. But if it is separate from the tumor, it means that the tumor is different. It's not from the optic nerve. The next thing what we'll see is the tumor lateral to the optic nerve or medial to the optic nerve. If it is lateral to the optic nerve, we can remove the lateral bone if necessary and take it out like this. That is the lateral orbitotomy. So lateral orbitotomy is indicated in lesions lateral to optic nerve. But if the lesion is medial to the optic nerve, as in this case, we do the anterolateral orbitotomy. So in this, what we do is, we do a lateral orbitotomy, remove the bone if necessary, do the canthotomy, and then disinsert the medial rectus and pull the eyeball medially, and between the medial eyeball and the separated disinserted medial rectus, in this space we work out and remove the tumor and then reinsert the medial rectus. This is called anterolateral orbitotomy. If the lesion is small and is at the apex, its transcoronal approach is the best way, refer to a neurosurgeon. So for the lateral orbitotomy, these are the three approaches. The yellow line which starts from the middle or a little on the medial side, below the brow, and then goes down vertically, and then has a horizontal. So it has three incisions separately. One is horizontal, then a vertical, then a horizontal. This is stellar right incision. Both the horizontal parts of the incisions are very well masked, but the vertical is not. The advantage is that it gives a big space. The disadvantage, it's not disturbing the canthus, but the disadvantage is that it leaves a vertical scar. I am yet to do a stellar right incision because I'm not very keen with the vertical scar. I prefer the other two incisions. That's my personal opinion. The second incision is the superior lid crease incision, which goes along the superior lid crease, comes down a few millimeters behind the lateral canthus and has a horizontal incision which goes through the crow's feet. So all this incision which is in the lid crease is very well masked, and this horizontal incision is also very well masked in the crow's feet. This is a beautiful incision for a big tumor in the intercorneal space. But the disadvantage is sometimes you may be damaging the LPS and may cause a ptosis. The third is Reisberg's incision, which is my favorite incision. In Reese-Berg incision, you split the lateral canthus, go a vertical, horizontal incision along the crow's feet for about 4 to 5 centimeters. Then you go ahead to the bone. So we'll go to the procedures. Lateral orbitotomy by Reese-Berg incision, which is, as I said, is my workhorse procedure. Before you, if this is, all these procedures are done under general anesthesia. Before we start, the first thing that we do is we identify the lateral rectus muscle and pass a sixo widely into it, so that later it helps us in identifying the muscle, so that we can identify it, retract it, and do the dissection without damaging the lateral rectus and without causing diplopia. So this is the horizontal incision that is given at the lateral canthus, and then you are carrying out the dissection both superiorly and inferiorly. And then once you find the bone about 3 millimeters and parallel to the orbital margin, make an incision and separate the periosteum, and then separate the periosteum and expose the entire zygoma. Then you can see zygoma, frontozygomatic suture. 4 millimeters above that you can go, and below almost up to the, as it moves, becomes the lateral wall, fill that. So such a big bone you can easily remove. So this is the bone that has been incised and removed with rongers. Then this is the periosteum that is there when the bone is removed. This periosteum is incised. Either it can be split straight vertically, passing the traction sutures here, so that you will be able to identify it, and later suture the periosteum. Then or it could be a U-shaped incision. I go usually do a vertical split, and then I put traction sutures on either side of it and then split it, and go almost for about 4 to 5 centimeters, almost up to the apex. Separate the periosteum so that it couldn't be. Then you identify the lateral rectus muscle with the help of the suture that we have already placed, right? And then you retract it to a side, and then in this you gently separate the fat and make a gentle dissection with the artery forceps till you see the tumor. Separate the tumor capsule from the surrounding structures, and then put a cryo. This cryo probe is a retina cryo probe with minus 78 degrees centigrade, that you keep it over it and gently sway it and remove the tumor from it. So this is how the tumor is removed with the intact, with the capsule intact, with the help of the magic wand, that is the cryo. Then suture the periosteum, put back the bone, drill 2 small holes in the bone that you have removed, and also then make 2 small holes here and here also in the remaining parts. Put the bone back and tie it with non-absorbable, that's 40 proline sutures. Then close the incision with 6O vicryl interrupted sutures. And if you want to put a drain, make a separate stab incision through which you pass the drain, and pass a suture through the drain, through the skin, so that it doesn't get disturbed, and then put pad and bandage. So these are the steps of lateral orbitotomy by Reese-Berg incision. So this is a case of a huge cavernous hemangioma in the intracorneal space with excavation of the bone with severe proptosis and exposure, which I removed intact through superior lip crease incision, and that's how the patient was here after the surgery, 1 month down the lane. But if you look at, there is enough ophthalmos. This is because this huge tumor has damaged some amount of fat. More than that, because of the excavation of the bones, the orbital volume is also increased. Because of the two factors, even though we do a good job, there will be some amount of enough mass when the proptosis is gross. So superior decrease incision goes along the lip crease and a few millimeters from the lateral canvas, right? So the incision is made and gently separated in skin and orbicularis. Don't try to incise the orbital septum, because if you damage the orbital septum, you will be sitting on the LPS. Then you at the lateral and you incise the tissues and go onto the bone, expose the bone. Again, similar to that of Leesburg incision, this is the frontozygomatic suture. A little above that you can make the cut. Below you can make a cut. Remove the bone inside the periorbita. Hold the tumor and expose the tumor. Hold it with a cryoprobe and gently dissect it out from the surrounding structure, and then get the hemostasis secure. Put back the bone, suture the periosteum, put back the bone, suture the periosteum above the bone, and suture the incision. Lateral orbitotomy, stellar right incision. These slides are not mine, they are from my book. The chapter was contributed by Ramesh and Santosh Manohar and their team. So these are, because as I said, stellar right incision I never do. So far I have never done, and I don't think that I will ever do it. Here is a severe axial proptosis with a huge mass involving the interpondal space that you can see in the coronal section as well as the axial cut, and you can see how much the orbit volume is increased when compared to the orbit of the opposite side because of the long-standing tumor and excavation that is happening. You can see the medial is coming almost up to this. So this is the incision that is made, and the incision is made along with that, and the skin and orbicularis are separated. Then medially expose the bone, and then the bone has been cut. Incisions are made, the bone is cut, and then the periosteum is incised. This is the tumor. The tumor has been removed, and incision is closed with interrupted schizovital sutures. I'm worried about this vertical. This scar is something that's what I don't like. I dislike the plan. If the tumor is medial to the optic nerve, I said that we will do anterolateral orbital. What is anterolateral? Let's suppose this is the eyeball, this is the medial rectus, this is the lateral rectus, the yellow one is the optic nerve, and this pink mass is the tumor, clear-cut tumor. Here you have the lateral wall, and this is the vein, and here is the temporal mass. So what we do is, we do a canthotomy and cantholepsis, and if necessary, if the tumor is too big, we can remove the bone zygoma as in case of a lateral orbital. Then what you do? You make a 180-degree conjunctival peritomy, separate the conjunctiva, identify the medial rectus, pass a 6-0 vital sutures with whip stitches on either side, and disinsert it. Now what we can do? Since now we have created space on the lateral side, you can put a retractor and pull the globe laterally. Similarly, the medial rectus can be pressed with a retractor against the medial wall. So in between you have space. Work out in this space, identify the tumor and take it out with the help of a cryo. This is anterolateral orbital. Here you can see this patient had a proptosis of the left eye axial proptosis, and the CT scan shows a big mass and in the intracorneal space, and it is separate from the optic nerve. This is the CT scan showing axial view of the huge mass with the optic nerve. Since it is medial to the optic nerve, if you want to do a lateral orbitotomy and approach like this, there is every chance that you can damage the optic nerve while you are trying to remove it out. That's why we have to do a anterolateral orbitotomy. So this is the lateral canthotomy and cantholysis, and the tissues have been removed and bone is removed, so that I have created space here. Then I did a 180 degrees peritomy, conjunctiva was removed, going the incisions going along the limbus from 12 to 6 o'clock position, and then vertically down almost up to the fornix. Then the medial rectus has been identified, it has been hooked, and the suture is passed, and the medial rectus, this is the sutures, and the medial rectus has been disinserted. Then the eyeball is pushed with one retractor. The medial rectus, this is the eyeball that's pushed laterally. The medial rectus is pushed here, and there is space between the two through which we are working. So there will be fat initially. Just you separate the fat gently with artery forceps, you will be able to find the tumor. So this is the tumor. The T is the tumor in between the two. The tumor is held with cryoprobe, and then what? The tumor is gently removed. So this is the encapsulated tumor that has been removed with the cryoprobe. I always use a cryoprobe to hold the tumor because it has a firm grip. It doesn't rupture the capsule. So the chances that you are able to remove the entire tumor encapsulated are very, very high with a cryo. If necessary, you can defreeze it. You can change the position where you are holding it a little posteriorly probably and pick it up. So never do this dissection blindly. That is very, very important. As long as we don't do the dissections blindly, we do not cause damage to optic nerve, and the vision will not be lost. Then the medial rectus has been again reinserted to its incision. The peritomy is closed. Then the canthotomy will be closed. If the lesion is in the superior peripheral space, the incisions are subciliary incision and lip crease incision. Superior lip crease incision. So these two are the things that are available. I prefer the superior lip crease incision. Here you can see a mass. CT shows that it is a small mass, not a very big one, of lacrimal gland adenoma. You can see that there is fullness here on the lateral side, superolaterally. Eyeball is pushed down a little medially. So what I did for this, I did a subbrow incision. Identify the mass, just incise the periosteum here, identify the mass, and take it out again with a cryo. This is the lacrimal gland that has been removed. A subbrow incision. When the tumor is small for the lacrimal gland, we can do it with a subbrow incision or a superior lip crease incision. If it is big, and if you are suspecting it to be malignant, then only we will be doing the lateral orbitotomy. This is the superior lip crease incision through which I have removed the small tumor that is present there in the orbit, and then sutured it. You can see this is the first course of the day. You can see that this incision is so well hidden in the lip crease that it will not make any mark. It will not lead to any scar. So that is the importance of a superior lip crease incision. Even a temporal dermoid can be removed with a superior lip crease incision rather than an incision straight on the dermoid on the temporal side. We can remove it without leaving any visible scar. I don't do the Byron-Smith's technique. That's why I am not showing that. I don't like the Byron-Smith because of the vertical scar. For the medial surgical space where the peripheral space where the lesions are there, you have transcutaneous approach, that is the lens incision or modified lesions. Or you have a transconjunctival, either a limbal incision or a subcaruncular incision, through which you can gain access to the medial peripheral surgical space. This is the limbal incision, this is the subcaruncular incision, this is the transcutaneous lynch incision. So this patient had a huge osteoma from the ethmoid bone with proptosis, and the optic nerve is getting compressed. There are very few cases in the world literature where a osteoma of the ethmoid compressing of the optic nerve has been present. Right? So it has been removed through a modified Lynch incision. You can see the shape of oscillated appearance label there. This is the attachment to the ethmoid, and this is the osteoma that has been removed through a modified, a little larger Lynch incision. Inferior peripheral surgical space. For inferior peripheral surgical space lesions, there are both transcutaneous and transconjunctival and swinging lower lid approach. Transcutaneous could be subsidiary below the eyelid, or it could be along the orbital margin. This leaves a bad scar. It could be a subsidiary incision, or better still, a swinging lower lid incision, which will probably show in pictures. Otherwise, you can go for a transconjunctival approach so that you do not leave the scar. So this is a cystic lesion which is transluminant, which has been removed transconjunctivally. The first post-operative day, you see that there is no scar at all, but very minimal swelling here. She looks pretty good. Under case of a granuloma that is present, which has been removed transconjunctivally, pars elite suture, margin suture, and could deliver over some spatula, and then work in the conjunctiva and remove the tumor and close it. First post-operative, the patient looks great. Swinging lower lid. Of course, I have done this, but I didn't have photographs. These were again from Ramesh, who has contributed for my textbook in the chapter on the orbitotomies. So this is from him. You can see the axial proptosis here. And there is a swelling here and fullness here that you can see. And the CT showed a mass in the peripheral inferior surgical space. Right. So this is the eye with the eyeball pushed up and fullness here. So what we do? Under general, compress the lateral canthus, then cut it, incise the lateral canthotomy, and change the direction to cut the lateral canthal tendon. Once the lateral canthal tendon is cut, what you can do is you can identify the bone, and then you can separate the conjunctiva, incise the conjunctiva from the lower bone of the tarsus and make a dissection in this plane. Anteriorly, you have the skin and the orbicularis oculi and the detractors. Here you have conjunctiva. So in this plane, you go identify the bone, then incise about 3 millimeters in front of periosteum, and between the periosteum and bone, you are in the peripheral surgical space. If you are having a fracture to be repaired, or if you have to do a thyroid orbital decompression, you can work in this plane between the periosteum and the bone. Or if it is a lesion in the peripheral surgical space, you can incise the periosteum on the lesion and work in that. So the tumor is held with forceps and the tumor has been removed. the conjunctiva that has been incised is repaired again, and the canthotomy campholysis is repaired with interrupted sutures. This is swinging lower lip. Here is case of bilateral thyroid associated arthropathy with severe proptosis. You can see that there is a engorged extraocular muscles. All the four muscles are grossly engorged, and there is an apical compression with optic nerve compression, for which I did a swinging lower lip approach and removed some fat and did three-wall orbital decompression. This is preoperative. This is postoperative. You see that the scar in the crow's feet has healed so well that there is no scar visible at all about 6 months after surgery. And the vision has, she has regained 6/6 vision. Exenteration, when the tumor is malignant and infiltrating, or if there is a lid mass that has gone into the orbital extension, we do a exenteration. So here normally what we do is we give an incision over the orbital margin 360 degrees, go up to the periosteum and separate the periosteum from the bone, go up to the apex and then remove it entire mass. This is a case of cystic carcinoma. You can see a big tumor of the lacrimal gland with irregularities of the bone that we have here. And you can see fullness, and the eyeball push it down. And so biopsy was cystic carcinoma. She was actually a feeding mother, young lady. So this I have done about 25 years back. At that time, exenteration was the only treatment for cystic carcinoma. Now it's only we access the mass and subject the patient to radiotherapy. There is a change in the protocol of the management for cystic carcinoma of the lacrimal gland. So I did an exenteration. This is what I said. Go on to the tissue, and that's how she has healed well. And she has camouflaging it with a dark glasses because she can't afford a prosthesis. So the take-home messages are nearly 50% of cases of proptosis are managed non-surgically. A thorough clinical evaluation and imaging are mandatory for every case. The only exception may be very early thyroid orbitopathy in a young patient where the clinical picture is sure, you are very certain about it, and probably you are observing. Other than that, in every case of proptosis, otherwise, we would like to get a CT scan done. Observation and reassurance is the only treatment that is needed in varix and many cases of thyroid-associated orbitopathy. Infections and inflammations are treated very well with medical management. Infections with intravenous antibiotics, inflammations with steroids, and parasitic infestations like myocystic sarcosis with specific drug albendazole plus prednisolone. If you have a suspicion that the tumor is metastatic or a malignancy and is very infiltrating, then you can do a fine needle aspiration cytology, but you should have access to a very good pathologist to interpret that. For a lymphoma, you can do a biopsy is the only simple thing that we can do. Identify or establish the diagnosis and go for radiation. Refer to a radiation oncologist. Similarly, optic nerve sheath meningioma, in some places, especially in UK, the CT imaging itself is diagnostic and they give radiation without asking for histopathology. But in India and even in America, when I was doing my fellowship, we used to do a lateral orbitotomy, take a small biopsy, get a histopathological confirmation, and then subject to review. Orbitotomy approach depends on the location of the lesion. If it is intracorneal, separate from the optic nerve and lateral to the optic nerve, we do the lateral orbitotomy. For me, the approaches are Reisberg's and superior increase incision of Harris. Intracorneal in location and medial to optic nerve, I will do anterolateral orbitotomy. Peripheral space, you have both cutaneous and transconjunctival approaches. Transconjunctival approaches are preferred because it doesn't give a scar. A transconjunctival and swinging lower lid approach and superior increase approach are popular because they give adequate space and there is no scar, no visible scar. Thank you all.
Thank you, sir. Thank you very much for the wonderful presentation, sir.
Thank you. Hope it is useful for the PGs.
Yeah, definitely, sir.
Residents. Any questions? No questions, right? Sudhakar?
Yeah, yes. Yes, sir. No questions, sir.
There are no.
Yes.
Okay. Thank you.
You can conclude the session, sir.
So,
Yes, sir.
so now we can close the chapter. Now we
Yes.
can conclude it.
Yes.
Right. So this is the approach, a clinical approach, how to deal with a case of proptosis. That's after thorough clinical evaluation and after thorough imaging. Then we are planning the treatment depending upon the etiology and on the location where it is. I did not speak on the multi-specialty approaches because it will be too long and probably they may not be needed for a postgraduate student to know them, the multi-specialty approaches. Okay, thank you all.
Thank you, sir.
Shall we close it?
Yeah, yes, sir. You can close the
Right.
session.
Okay, thank you. Tena?